Sickle cell disease, chapter 34. So what is happening in the body? You have abnormal shaped hemoglobin that stems from a genetic trait. So sickle cell disease is caused by inheriting 2 copies, so one from each parent, of an altered HBB gene. This causes the production of an abnormal, distorted hemoglobin that tends to clump and stick together and form hemoglobin chains. When this happens, it causes the obstruction and worsening hypoxia that in turn can lead to tissue ischemia, injury, and pain. So on assessment, you would want to get a thorough history. Is there any family history of a sickle cell disease or the sickle cell trait? Does the patient have any previous episodes? Each time a client experiences a sickle cell crisis, it causes damage to tissue and organs. Do they have any recent signs and symptoms of infection? Or have they experienced any recent events that may have led to the current crisis? Lifespan for sickle cell disease patients usually ranges between 42 and 48 years old, depending on their gender. So for your physical exam findings, you'll see the most common symptom is pain. This is due to hypoxia and impaired perfusion that leads to that tissue ischemia and injury. You want to assess for any changes in mental status or behavior changes. Often cognitive and behavioral changes are the early indications of cerebral hypoxia from that poor perfusion. Assess the peripheral pulses, their temperature, and capillary refill, and look for any evidence of cyanosis in all their extremities because of that impaired perfusion. Fatigue is the most common symptom of anemia. Can also be found in sickle cell disease crisis. Assess for jaundice because of the red blood cell destruction and bilirubin released. And priapism is a disorder in which the penis maintains a prolonged rigid erection in the absence of appropriate stimulation. Definitions vary regarding the duration, but any erection that lasts longer than 4 hours is generally considered priapism, and it's painful and unable to void during an episode. Lab findings, their H&H will be low and the WBC will be high due to the chronic inflammation and tissue injury. Reticulocyte count is high, which indicates anemia of a long duration. The bilirubin level may be high and blood transfusions may be warranted, so you would want to add a typing cross in your lab draw. The laboratory assessment for screening purposes would be a sickle cell screen or a hemoglobin S screen to see if they have the genetic disorder or genetic trait. Tests that can be performed: an X-ray. An X-ray may show some bone changes, especially in the skull. The skull will have a crew-cut appearance, and that's due to the bone surface cell destruction and new growth. And joints may show necrosis or destruction. Ultrasonography, CT, positron emission tomography or PET scan, and an MRI may show soft tissue and organ changes from that poor perfusion and also chronic inflammation. ECG changes indicate cardiac infarcts and tissue damage. Echocardiograms may show cardiomyopathy and decreased cardiac output or a low ejection fraction. The problem in anticipated hypothesis includes pain due to poor tissue perfusion, hypoxia, and joint destruction as a result of the abnormal shaped RBCs clumping together. The desired outcome is reported pain to be maintained at an acceptable level. We want to maintain perfusion and gas exchange to extremities and vital organs. This is achieved by addressing the ABCs and pain. Box 34.1 tells you the best practice for care of patient in a sickle cell crisis. This includes removing constrictive clothing, encouraging extension of extremities to promote venous return, not raising the knee position of the bed, and keeping the head of the bed no more than 30 degrees. You want to administer oxygen and anticipate ABGs and chest x-ray. Oxygen is given during a crisis because lack of oxygen is the main cause of sickling. You want to infuse normal saline intravenously and then be prepared to administer transfusion therapy if ordered. Keep the room temperature comfortable and not too cool, and then check the circulation in the extremities every hour. Pulse oximetry of fingers and toes, peripheral pulses, and capillary refills should be checked. Lots of opioids are needed for that initial pain management in an inpatient care setting. So IV analgesics should be prescribed for the first 48 hours. Many patients have negative interactions with nurses who suggest that patients with sickle cell disease may be seeking drugs. And then the concerns about substance abuse can lead to inadequate treatment. Even if patients are addicted, if they are in acute pain crisis, they still need opioids. So making sure that we are adequately medicating patients for their pain and controlling their pain. Hydroxyurea is another medication that may be administered. Hydroxyurea helps decrease the number of sickling and pain. It produces this effect in some, but not all, patients, but it is still considered a mainstay of management as it decreases vaso-occlusive occurrences. Hydroxyurea can also decrease bone marrow function and immunity, and it increases the risk of leukemia. Hydration is another medical management. And then integrative therapies such as keeping the room warm, using distraction and relaxation techniques, positioning with support for painful areas, warm soaks or compresses, reduce environmental noise, all help to reduce pain perception. The next problem or anticipated hypothesis is the potential for infection, sepsis, multiple organ dysfunction syndrome, or MODS, and death due to damage sustained to spleen from intermittent ischemia. Our desired outcome is for the patient to remain free of infection, sepsis, and multiple organ dysfunction syndrome. This is achieved by prevention and early detection strategies. So we will want to take vital signs every 4 hours to rule out infection and sepsis. Provide frequent assessments to look for opportunistic infections with focused nursing assessments, diagnostics, and labs. Frequent hand washing is the best way to prevent infection, and patients with fever are started on prophylactic penicillin or erythromycin if they're allergic to penicillin. This is a protective strategy. So risk factors of sickle cell disease. There are non-modifiable risk factors, and this is a sickle cell trait, and different forms of sickle cell disease occur in people of all races and ethnicities, but they're most common among African Americans in the United States. Some modifiable risk factors include dehydration, hypoxia, infection, pregnancy, alcohol abuse, high or low temperatures, acidosis, strenuous exercise, stress, nicotine, and anesthesia. Usually, after the underlying factor has been resolved, the sickled cell will resume its normal, healthy shape. So some complications. The patients with sickle cell disease has periodic episodes of extensive RBC sickling. This is called a pain crisis or a vaso-occlusive crisis. The crises have a sudden onset and can occur as often as every few weeks or as seldom as once a year. And many patients are in good health much of the time, with the crisis occurring only in response to triggers. It can cause extreme pain, organ damage, perfusion and oxygenation issues, risk of infection, and early death. So for patient teaching, we want to teach about management and prevention. We want to assess their support systems, assess their understanding of the disease process, and what positive coping patterns related to the disease progression. Urge the patient to receive their pneumonia vaccines, annual flu vaccines, COVID-19 vaccines as recommended by their healthcare provider. And then stress the recognition of the early symptoms of crisis or infection so interventions can be started early to prevent pain, complications, and permanent tissue damage. We also want to teach the patient and family the correct use of opioid analgesics at home. And box 34.2 in your book shows patient and family education for prevention of sickle cell crisis. So to evaluate, the patient's pain should be maintained at an acceptable level. We want to maintain perfusion and gas exchange to extremities and vital organs, and then remain free of infection, sepsis, and multiple organ dysfunction syndrome. Thank you.